both in independent pharmacy, community pharmacy, and primarily grocery store pharmacy. And trying to help navigate patients through these myriad of barriers. And that gets to what our members are focusing on through the Illinois Pharmacists Association, trying to help navigate and connect patients to care and access to their medications affordably, and to keep them on their medications. That's the key part here, is we can sometimes get them connected for one medication, but then things change, formularies change, the rebates change, which forces patients into this unending loop of trying to stay healthy. And that's what our members are trying to do. At the same time, being forced to provide this care under their operational costs. And that is then having a systematic dramatic effect on pharmacy. We have 74 of our 102 counties are pharmacy deserts. That should concern every person in this room today, that we do not have enough pharmacies in our state to support the care. And it's not just a rural Illinois problem. That's a common misconception. Cook County is a pharmacy desert. DuPage County is a pharmacy desert. Will County is a pharmacy desert. That should show you we really need to stop talking about this issue, and we need to start acting on this issue.
Absolutely. Chris, question to you, can you just tell us a bit about the steps that you and your organization are taking in this kind of greater effort to address prescription drug costs?
Yeah, I think, what Garth mentioned is, access to care. I think that's one of the biggest things the problems that we're facing in terms of pharmacy deserts, healthcare deserts in Illinois. And, so I'm Chris Crank. I'm the Executive Vice President of ICHP. My background is as a hospital pharmacist or a health system pharmacist. That means inpatient, that means in clinics within the organization, specialty pharmacy. I was actually involved in the start. I helped lead the opening of the Rush University Medical Center Specialty Pharmacy. So I have a lot of inpatient experience, but also that connection to the community and retail pharmacy. I think the U.S. drug system is extremely complex. There are things like the fact, why does the U.S. pay more than other countries? Well, there's one negotiator in some other countries. That's not the system in the United States. But there are a lot of systematic issues in place that really do drive increased drug costs. And so what I would say ICHP looks to improve access and affordability for our patients or the patients that our pharmacists take care of across the state. That could involve infusion centers, that could involve community settings, and hopefully also in the inpatient setting. I think part of that discussion is why we're here. When we talk about PBM reform, we talk about 340B protections. There's a lot of topics that are being discussed in Illinois about how to maintain access to care, which is for us medications, and also how we basically make those drugs.
Definitely. Thank you, Chris. You kind of gave a preview of what we're going to be going into later here. Representative Manley, I want to go to you just from the lawmakers' perspective. Just kind of, what is your role, you and your colleagues, in this effort to address prescription drug costs?
Good question. I am not an expert, but I will tell you that I have learned something from everybody on this panel, mostly because I was catapulted into this role. I was like one of those innocent bystanders. You're going to now be the chair of Healthcare Access and Availability Committee. And oh, by the way, you're going to deal with the PBM issue. I'm like, what is that? So if you're like me, I'm a CPA. This is a really tough day for me to be here. I thought that it's something that I have dedicated my time to over the last year or so, and trying to learn hours and hours of making many people sitting here come and talk to me and teach me, and I still feel like I know so little. So we're lucky to have the experts here with us. Is there anybody in this room that doesn't themselves or know somebody that takes life-saving medication on a daily basis? Right? So we all know someone, if not ourselves. This is worst setup for a panel, by the way. Like, I didn't wear a dress today. We have to make it affordable. I know seniors that ration out their medicines. And I don't want to, and I think what we should do is not blame any one person. Pharma knows what this feels like. You know, you've been called Big Pharma because that was the easiest little, I don't know, like fake news kind of thing that we can say. People were saying Big Pharma, they're the blame. I don't want to blame anyone. I just want to fix it. Mm-hmm. So the role of the legislature is to figure out how to fix it, how to keep people from having to ration their medicines, how to keep pharmacies in business and located somewhere close by. And for those that have said, well, there's mail order, have you tried to mail anything lately? It doesn't get there. It's months. So, I don't know, your heart medicine doesn't show up for 3-4 weeks. Now what do you do? So these are real issues that people all over the state are facing. And so that's our job. We're going to fix it. We're magical in Springfield. We're going to magically fix it.
Absolutely. Thank you, Representative. Johnny, I want to go to you on that. Just kind of, what are some of the steps that PCMA and your members that are taking in this effort to address prescription drug cost?
Yeah, thanks, Ryan, and thanks, Rep. I think a lot of us have the same sentiment about making sure patients are first, right? So that's access, cost, whatever we're seeing. And it's quite a bit right now. Medications are going up in price. We've got a sicker population. More people are getting sick. They're living longer. They have more chronic diseases. The median cost of a medication is $300,000, right? Let that sink in. Who can afford that, right? It's pricey. And you're basically choosing between life or taking a medication. So it's a tough place to be right now. So, we're looking at our members are looking at different ways to innovate right now. We're going through a huge innovation stage where we're looking at how do we support different programs for patients, both through adherence, making sure they're taking the medications correctly and on time, also bringing down the costs. So using generics when possible, offering those as a $0 copay, usually for preventative medications. So disease states that diabetes, things that can be prevented, cholesterol, things like that. So we want to also make sure that we maintain options for our plan sponsors. So when they're doing contracting, they have options. If they want to use mail order, they should have that option to use mail order. If they want to include every pharmacy in their network, great. We also need to support the local pharmacists. We definitely agree with that. Pharmacists are critical to our networks and making sure that people have an option to drive to, making sure that we can meet network adequacy standards, even for some of the federal programs. So we're looking at all the things that everybody else here has already talked about.
Wonderful. Great. Peter, let's go to you on that. Just kind of maybe just talk about from the pharma perspective, just kind of what are some of the steps that you and your group are taking in this effort?
Yeah, I think it's the theme is going to ring all the way through, but access for patients is number one issue for all of us. The pharmaceutical industry is spending roughly, I think it's almost $300 billion a year in rebates across all payers, and our number one priority is to make sure that the patients share in those savings that we're trying to pass down. The rebates are the negotiation from the list price to what the patient actually pays, but they're not seeing some of that money. It's getting held up in the supply chain among multiple actors. Also, access with the doctor-patient relationship is very important. The state of Illinois did a great thing last year and did away with step therapy, put some more restrictions on prior authorization. Those are great moves to ensure that the patient-doctor relationship remains at the center of all healthcare, and that's something that we've really paid a lot of attention to. But at least from a federal perspective, just want to touch on that, is ensuring our companies can stay innovative and develop the next generation of cures and treatments for chronic diseases, and honestly, diseases that can be fatal at some point. The IRA in D.C. did a lot of, I would say, damage to that innovation kind of ecosystem, and our companies are trying their best to adapt to it and make sure that those cures can still be developed. But there's some issues there that we're going to be dealing with in the federal level. But overall, it really is just a patient-focused, first dollar coverage on high medical healthcare plans for chronic diseases is a great thing that states could be doing. There's a lot of activity state legislatures can be taking to make sure that patients are getting their drugs, they're not paying too much at the pharmacy counter, they're getting discounts to ensure that there's no issue for access and that they're not rationing medication at any given time.
Wonderful, great. Lou, last, certainly not least, I wonder if you could weigh in on this, kind of talk a little bit about what some of your members are doing in this effort to address cost.
Thanks, Ryan. I'd love to chat more from my journey a little bit.
Yeah, of course.
So my journey is a little unique, the fact that in this role that I sit in as the president and CEO of the Illinois Chamber of Commerce, I didn't come from the policy world. I didn't come from inside the dome. I came from the business world. So the first third of my career was in pharma and biotech, basically negotiating major contracts. Then as a business owner and grower and entrepreneur, I've seen the rising costs firsthand of healthcare. 13% per annum per year, and so, it's really from our perspective at the Chamber, we really look, and I appreciate the fact that we've got so many sponsorships because we represent a lot of these companies that are up on the panel, but, for us, it's really, it's minimizing the bureaucracy and a lot of the, we'll call it tax policies, and in some cases, the unfunded mandates that imbalance the business environment for the business community. That makes it tougher to be profitable, and that includes the pharmacy sector as well. Rising property taxes. I guess they didn't like that. Right? Rising property taxes, mandates on how you run your employees. All these unfunded issues that basically cause problems with running a business in the state of Illinois.
Mm-hmm.
I mean, Cranes referred to this a couple of weeks ago in an op-ed, basically saying, hey, if we're doing so great as a state, how come we're lagging everybody else? And I think that there isn't a sector that isn't touched by some of these issues in the state of Illinois, healthcare being one of them. Because healthcare, like anything else, is a business,
Mm-hmm. Absolutely. And Lou, I want to kind of stay with you and just kind of delve more into that. Just kind of, what do you see as some of the biggest challenges, specifically related to prescription drug costs?
Well, when you look at it, it's simply, again, I'm going to go back to the overregulation. I think all of this policy that's being thrown right now in Springfield is well intended, right? Mm-hmm. But it's like it's a little bit of what we're seeing in Washington when you dump all the pencils out and throw it all at the wall and say, all right, so how do we do this? It's all of this without fully understanding the implications of it. To every action, there's a reaction and there's impact. And I think when you throw all of these issues on the table without fully thinking through it, you create a problem. And there's an unintended consequence. I'll take a simple one here, and just outside the healthcare spectrum. Paid leave act. There's a lot of employers that have done that for a long time, right? But when you create 3 different statutes, City of Chicago, County of Cook, and the State of Illinois, you now have, with a 7-day notice, you now have challenges that pharmacists are having to deal with. You have challenges that employers are having to deal with in managing staffing their workforce. That impacts quality of care. That impacts in hospitals. That impacts the ability to do remote procedures. When you've got surgeons that are now calling off on select procedures, the hospital schedulers have to figure out, all right, so now who do we call in to cover the staff? So this is the unintended impact of some of this policy, not thinking it full through, and most importantly, not having business at the table.
Mm-hmm. Absolutely. Garth, I want to go over to you on this question just as we talk about, you should have a second mic somewhere. Oh, okay, great. Garth, I want to go to you on, as we talk about, drug costs, just what do you see as the biggest challenges related to this?
Well, that question alone could keep us here all day. But a lot of this gets back to a couple different factors. One, we have numerous amount of rebates that are being extracted from pharma by some of the other actors, whether it's PBMs or rebate aggregators. And those rebates are not getting down to their intended individual, which is the employer and ultimately the patient. And that alone should be a primary focus of policy. But in addition to other aspects as well is looking at the spread pricing and this issue of that we are saying we paid for this medication over here at X price. We're reimbursing pharmacies at Y price. Sometimes we're telling the government or the employer a Z price. And there's a lot of information in the data and money being manipulated and siphoned away and being extracted. And again, that's not just conjecture. Illinois looked at this. They found $200 million to spread in Medicaid in just 2 years. CVS had to pay a fine for doing that exact same thing in the state employee health care plan and had to pay a fine of $46 million. Just to put that in perspective, $46 million, I think, for most of us in this room is a hell of a lot of money. but that was 0.05% of the revenue that CVS Caremark made in that quarter, $95.4 billion. That's more than the state is projecting to spend in their budget this year. That's one company. So the three major ones were at $900 billion last year in revenue. And most of that is extracted from all these different components and silos of the pharmacy supply chain, whether it's pharma, employers, and pharmacies. And we got pharmacies crumbling. We got 3,170 pharmacies closed last year in the United States. Over 80 of those in Illinois. That alone should make every one of you want you to call your legislator and go, we have to stop this right now. Because in comparison, Illinois from 2013 to 2023 lost 400 pharmacies. That alone is egregious. But losing 80 in 1 year shows that we are past the critical point. And so we really have to start looking at this. And I appreciate the concerns of additional business costs. But when we have sacrificed other businesses for the scamming done by other components of the sector, we have to stop this and we have to start appropriately paying pharmacies. And because I'll say one quick example of that. In construction, show me a construction company that would fix I-55, not get paid for the asphalt that they're putting down until they can't pay any of their labor of their workforce doing it. That's what we're doing with pharmacy with each individual prescription today. So we have to fix the spread, we have to fix rebates, and we have to bring actually paying for healthcare back to it. And it's not going to cost anything, it's just not going into the pockets of one person anymore. And it's actually going to be going to the sectors that it should have been going since day one.
And I'll give everyone a chance to respond in a little bit, but Chris, I wanted to ask you first, just kind of, if you kind of want to weigh in a little bit, what do you see as some of these biggest challenges related to prescription drug cost?
Well, I think a lot of what Garth said is what I would also say. I think, the impact of rebates on the list price of drugs can't be ignored. I know, really drug manufacturers are the only ones that can set drug prices, right? They do determine the list price of a drug. What I would ask is, well, who influences the list price? That's a key question. And I think there are players in the system that heavily influence the drug price. If you're the manufacturer, and again, I can't speak for them, right? I'm a pharmacist. I'm not in pharma. But if I sell a product for $100 and I know I'm going to have to pay a $40 rebate, what am I going to do? I'm going to raise the price to $120 or $140 to make up that difference. Then what happens? Well, then if there's percentages taken off that rebate, hey, I get a bigger percent, right, or a bigger amount because the total number is higher. And so it's a lot more complex than that. I've completely oversimplified it, but in reality, that happens in our system. Then you add in hospitals, pharmacies, other players, right? There's a lot of people involved in the drug market, wholesalers, and it gets extremely complex. But rebates are a big driver of some of the drug costs. I don't want to get into a debate of other countries and what they do versus the United States, because we can spend an hour on that too, right? Plus. But I think, the negotiating power is different in the United States. I think formulary management is different, right? PBMs control formulary management and access in the United States, not one central agency. That impacts cost and price. And then it's also all of the processes that we have in place that other countries, for instance, don't have in place. We have a lot more players involved.
So, Johnny, I want to go to you then on just kind of on this question about some of the biggest challenges in the prescription drug space. Kind of, what do you see as some of the challenges? And if you want to respond to some comments earlier, feel free.
Yeah, so I keep hearing a lot about the rebates, and a lot of the finger pointing typically comes back to PBMs with rebates. And so the rebates are passed through to the plan sponsor if they choose, or they're used to offset some of the cost of providing the pharmacy benefit services. So some money is kept back depending on how the contract is written. I think what we're hearing is that the rebates are the influence of the drug cost. That's not necessarily true either. We saw this with insulin specifically, where drug manufacturers lowered the cost of insulin, rebates went away, and it became more accessible. So we're all for lower list prices. A lot of the rebate system was designed from the 1990s, the Robinson-Patman Act. So if there is a redesign to carve drugs out of that act, it's also a suggestion, but that's at the federal level, nothing that the state can do. So we're for that as well. I think we're looking at ways to make sure that medications are affordable, attainable, still using the rebate system and having optionality. I also heard spread pricing. That's a contracting request that we had, and was developed because plan sponsors wanted a way to have a set cost instead of something that was fluctuating throughout the year based on drug prices, so on and so forth. So they wanted the option to pay for their contract in one set month, and then PBMs they take the risk. They either win with the money or they lose the money. We do take losses too on a spread contract. It's not always a game. So I think there's a lot of things in the market. It is complicated. The more you dive into it, the worse it gets. Yes, I understand that. Sorry.
Peter, I want to go to you on this guy. What do you see from your perspective as some of the biggest challenges in this prescription drug space?
I mean, I think some of the biggest challenges is, at least for our companies and our industry, I mean, when it comes to, who said it best, healthcare is a playing field. It's a finite sized playing field. There's multiple players kind of interacting and reacting to each other, and in a lot of cases contracting with one another. So when you touch some part of healthcare, there's going to be an effect somewhere else in the supply chain or in the system in general, especially when you start getting into multiple payers, Medicaid, Medicare, commercial insurance, and so on. But a lot of the challenges, I think, for our industry is the amount of, for Medicaid, Medicare Part D, and 340B, that represents about almost $350 billion in 1 year of drug spend right there alone. So having anything change in there, and those are rebates, those are discounts, what's left over for commercial insurance, where are those savings going to? Whenever we talk about list price and the rebates, those negotiations take place because the richer rebate gets higher placement on a formulary tier, and that ensures the product gets dispensed. It doesn't have to be that way. It can be put on different tiers, but at the end of the day, the system was set up a long time ago. It's a playing field that pharma was kind of placed on at some point, and we've had to react to that in the best way we can, and that's why we advocate more for pushing savings and these rebates down to the patient at the pharmacy counter, either in the form of a discount or co-pays or a reduction in their premiums. But the other big issue too is all the consolidation and vertical integration that's happened in healthcare, especially in the last 15 years. And this isn't just health insurers, PBMs, wholesalers, and so on, but also hospitals and clinics, physician practices, or outpatient surgical centers. It's all become one big system, more or less. I was thinking about this on the way over here, and I'll end with this. It's not necessarily relevant to Illinois, but for Cranes Detroit, there was an article back in February talking about how Blue Cross Blue Shield of Michigan lost $1 billion last year. They're the largest health insurer in Michigan. It serves about 4 million people. And the reason was hospital consolidation. Big three systems there, and 5 years ago represented 30% of the market, and now they're at 60% of the market. Good for them. They're getting paid probably what they should have been paid to begin with, but all that consolidation happening, all of that power is starting to take money away from another part of the system and creating more challenges. So it's like I said, every time you do something, there's a new challenge that pops up. It's kind of like a never-ending saga, unfortunately.
Absolutely. Great. Representative Manley, I want to go to you here. The Pritzker administration has made drug costs a priority this legislative session, specifically around PBMs. You're fortunate enough, you and Senator Kaler, to be carrying the legislation this spring. Can you just tell us a little bit about why this is such a priority for you and the administration this year?
I have so much to say. This is like the rantings of a lunatic. Thank God I can afford my prescription, because it would be like a lunatic talking up here. Governor Pritzker, to his credit, and his team have finally answered a call that people have been shouting this from the rooftops for years now, decades. Again, the unwitting victim of being thrown into this, but I'm so grateful because I'm learning a lot and being able to answer to my constituents their cries. This pharmacy is closing. We live in an area where several Walgreens are gone now, and we're about to lose one of the oldest pharmacies that is a specialty. It's a unique blend, but one of our specialty pharmacies is on the brink of closing. This is an old family pharmacy in Joliet that has been hanging on by a thread. So I think the governor, in his wisdom and his team, has decided enough's enough. This is really the issue of my lifetime. With so many people relying on medications and, as you said earlier, living longer, this is a huge, huge shift. It's complicated, and I think people have wanted to fix it in the past, but just didn't know where to start or what to do about it. It is extremely, I know more than I did 5 minutes ago, just by listening to these people on the panel. And so I have a couple of things to say. First of all, Lou Sandoval, I love you, and you are probably one of the most impressive people I've met in my life. Impressive man. You should get to know him. But paid leave, a business wouldn't feel it if they were doing things the right way to begin with. So when paid leave came into play, the only people that felt it were the people that weren't doing it right. And healthcare is a business, but the cost to people, I mean, if you own a restaurant, no one's going to die. But in healthcare, if the cost of doing business is someone's life, it's a cost too high. Johnny's shaking his head, yes. You're next. You talked about finger pointing. I don't want a finger point. I want to fix a problem. You guys have been really lucky for a long, long time that some genius came up with this business model. But now we're on to you. And then we're going to figure it out. We need your help. We need you to work with us so that people can get their medications and don't have to crack their pills in half. This is really happening out there. You guys make a lot of money, and I'm not trying to keep somebody from making money. I just don't want something like a vertically integrated system to be good for some while most people suffer because of it. That's what we're trying to do here. Let me see, who else have I left out of this?
Anyone else need to call out?
Okay. Pharmacies go. If the pharmacies are gone, where are we going to go? What if you don't have a car? Or public transportation doesn't come within walking distance? Where are they going to go? What are they going to do? The cost is too high, and we have to work together. No more finger pointing. We're going to talk about facts, and we're going to fix this. That's what the governor wants to do. And there's no downside to transparency.
Definitely. And Representative, we're about 6 weeks.
Did I answer everything except your question?
It was good. But I am curious, obviously we're about 6 weeks or so left of the legislative session. And I'm just curious, what is the status of this proposal? And when do you...
I wish I knew. To the governor's credit, they are bringing, and I don't know if everybody would agree, that good legislation is where everybody's unhappy, right? Because nobody got everything they wanted. But I think they're doing a really good job of getting everybody at the table, trying to listen, taking down suggestions, vetting different plans, different suggestions, if you will. And they're taking their time because whatever they bring it's going to go through the Senate first. Whatever Senator Kaler presents in committee will be the bill. That is what I'm being told at this point. So we're still waiting for whatever the end product is. But I think everybody who's been in negotiations has seen some form of it and been able to participate. Did you say that's true? Ish? Okay. Yeah, that's the impression I have.
Okay.
They're bringing every stakeholder to the table, whether they're listening and taking every suggestion. I don't know.
Okay, great. Johnny, I want to go to you, just kind of give you a chance to weigh on some of this discussion. Just where does PCMA stand on these legislative efforts, and just how might it affect, PBMs and, just the overall drug pipeline?
Yeah, I think, a lot of what we're hearing is transparency, and we are pro-transparency. The more information that's out there that can be taken and used and made actionable, the better, right? We're not opposed to that at all. We believe that it should be the entire drug supply chain, though. It's not just PBMs. It is definitely drug manufacturers, wholesalers, hospitals, pharmacies. Everybody should be at that table with where the costs are, because I think that's going to tell the best picture. So I think, the governor, we've worked with the governor's office on stuff. We've provided suggestions as well. Some of the stuff that we've talked about are also for some of the pharmacy protections. So PSAO model act that we have is, looking at the PSAOs that represent the independent pharmacies. Are they truly representing the independent pharmacies correctly? So they're not shutting their doors. Right? They manage about 80% of independent pharmacies. So things like that are where we would also like to see some of the legislation go, but definitely support the transparency.
Absolutely. Lou, I want to get your thoughts. What are your thoughts on this legislative effort, from the Pritzker administration and lawmakers?
Well, I'm gonna meet a compliment with a compliment. Because I love the fact that Leader Manley has been so insightful in leaning in and learning about this, because it is a very complicated. I mean, I spent 16 years in the industry negotiating this stuff, and it's a very complex supply chain. From manufacturers to intermediaries, wholesalers, retailers, and then ultimately to care providers. It is extremely complex, and all of those are businesses. They're all businesses, and they all should profit. One of the challenges that exist in the advent of ACA and the expansion of healthcare is you can't just expand healthcare without managing costs. Because it's like saying I don't have I don't. It doesn't matter if I fit in all my suits. I'm gonna just continue to eat. And eventually it becomes a problem. And that's kind of what we've got to kind of manage the costs related to that. I think Peter kind of hit it best with regards to his metaphor. I'm going to take it a little further. I think of healthcare as sort of like that wiener dog sausage balloon that we all use at kids' birthday parties. You squeeze one end of it, and the air goes to the other end. So it isn't that, because it is such a complex supply chain, it isn't that you're taking costs and just removing them from the ecosystem. You're basically shifting the cost. And that means some businesses feeling it. And then you add macroeconomic pressures like rising property taxes, cost of doing business. I mean, there's a statistic that came out, and I feel it, because as I travel the state, I live here in Chicago, but as I travel the state, I see the issues in Quincy, Illinois, when businesses leave an area and they're left with nothing. Some of those same towns are now pharmacy deserts because there's no investment in those areas. But then secondly, there's a statistic that came out in Wall Street Journal last year that the average American, 62% of us, pay more in property taxes and insurance than we do in our own mortgage. So think of the first one, property taxes. And we are one of the highest property tax states in the country. So when you look at those factors, that's why it's so hard for, one, people to live in Illinois, but two, businesses to ply their trade in Illinois. Because all of that gets factored into the cost of doing business.
Fantastic. Great. Garth, I want to go to you. You've been very vocal in your support of these efforts in the past. And why do you think it is so necessary that lawmakers address this issue? And just what are some of the pros and cons of these efforts?
Well, before I get to that, I do want to address one of the things that I usually love how this gets tossed out there, and that's about pharmacy services administrative organizations, or PSAOs. PSAOs, I will admit, as a pharmacist, that sometimes there can be constraints and issues with any type of organizational group that's trying to contract for a group of pharmacies, and that's what they do. There's one key component, though, that they're not able to negotiate, and that's on reimbursement. And we have to be open about that. Let's try to shift that they're not servicing their customers or the groups that they support. Because of antitrust, they're not able to negotiate the reimbursement component. So it is a take it or leave it contract just on a thousands of pharmacy level instead of a singular level. And that is still one of the constraints, but pharmacies continue to try to go to that avenue, even though they know they may not get the best deal, because it's better than not having any deal at all, which is what they would do if they were dealing with it separately. So, yes, PSAOs are not the perfect model, but until we get federal legislation that would allow them to collectively come to negotiators as a stronger unit, that's still going to be a continued issue. And that's going to be complicated. That's going to be a federal level because you've got so many different ownership and interests there. But on a state level, the proposals that are being considered by the governor's office and by the state of Illinois are not new concepts. Many states have looked at this and have continued to look at it even in this year. And every state that has passed, whether it's banning spread pricing, ensuring rebate dollars are actually going back to who they are instead of being mysteriously shipped off to unknown foreign entities which don't have any type of transparency whatsoever, which two of the three major aggregators are. Don't let them confuse you about that. And if we look at properly paying pharmacies, the ship does not go down in the sea. If anything, the ship is righted. We have to preserve access. All of us on here have talked about access to patients. Pharmacy closures is endangerment of access, plain and simple to the point. We have a member on our west side of Chicago who's had 4 Walgreens close around him. In years past, that would be an elation because we're like, oh great, all new business. It's primarily Medicare Part B and Medicaid, which right now means they're all poison darts. Because if he would try to help all of these patients, it would sink him today. So he's actually having to do the hardest thing that a pharmacist has to do sometimes to say, I can't help you, but I can try to direct you somewhere. And so that's the issues we're coming. We have the largest pharmacy in the state of Illinois struggling. That should tell everyone, again, this is a crisis, and it has to be righted. So, again, all of these states, whether it's West Virginia, Kentucky, Arkansas, Ohio, all have done these types of provisions of what's being talked at by the governor's office. And every one of these states has shown more savings than they had projected in return.
So, I want to make sure we get some other topics out so we could go all day on this one. But Chris, I want to go to you on and switch gears on another notable legislative effort this spring, and that's around 340B reform. You know, there's been discussions about there's been discussions about Illinois falling into steps of states like Arkansas and others that prohibit manufacturers from interfering with providers' ability to receive prescription drugs if contracted with the program. Other steps. Just can you talk a little bit about the 340B program and how these reforms could affect drug costs and access?
Yeah, so 340B, we're talking about PBMs and the drug supply chain in the United States. 340B is just as complex as that, maybe even more so. It's a federal statute that was intended to spread scarce federal resources to underserved communities, basically. And a lot of the discussion back and forth is, are the covered entities, the people who qualify for 340B, really doing that or not, right? And the organizations that pay for the 340B discount are the pharmaceutical manufacturers. And so there's automatically a little bit of a rub or an issue there. I think what's happening is a lot of hospitals and health systems are seeing their contract pharmacy networks limited by manufacturers. It's not outlined in the HRSA, in the 340B statute, but there's limitations being put on it. What that means is that it limits the health system's ability to utilize that 340B discount. And so that 340B discount can be used for many things. It can be to keep programs open that are not profitable, like mental health services. Maternity, right? OB services are less profitable in the state than they used to be. I think one of the things that's going to come up is transparency in the 340B program. There is already an audit process in place. Covered entities are audited on a regular basis anymore. HRSA, the federal agency that oversees 340B, also provides audits. But I think really the protections for 340B allow some of those critical access hospitals, some of those disproportionate share hospitals, Ryan White centers, and others to operate with a margin and to basically provide those programs and continue services that otherwise they might have to cut. So it's in my opinion, it's vital that the 340B savings be maintained to ensure that those organizations stay in operation, kind of like what we're talking about with pharmacy deserts.
Absolutely. Peter, I saw you already grabbed the mic. You knew I was coming to you next.
It was handed to me.
I know that PhRMA has been in opposition to these efforts in the past, and I wonder if you could just talk a little bit about that and kind of why you don't believe that this is the right step for states like Illinois to take in this effort.
Well, to be clear, the pharmaceutical industry has always supported the 340B program in its original intent, which was to serve uninsured and underinsured patients to ensure that they are able to afford the prescription drugs. It is at its core a prescription drug discount program. That's what it was passed as in 1992, and that's the way it was maintained for a long time until, honestly, the only time it was ever expanded via statute was in 2010 with the Affordable Care Act, which allowed for those critical access hospitals and disproportionate share hospitals, children's hospitals, a few others to join, which in turn made this program more of a hospital markup program than actual providing services and care. Big hospital systems make up about 87% of the system. So we're not talking about the FQHCs, the Blind White AIDS clinics, the community health centers, the black lung clinics in eastern Kentucky. We're talking about the large hospital systems in the states that have taken advantage of this program to maximize revenue any way they can. And that's by taking these drugs in at an average of 57 to 60% off and maximizing and then turn around and charging the list price for that drug for the patient. So patients, number one, don't know that they're 340B. Number two, aren't receiving the discounts. So that has always been our biggest problem here. And the growth of the program has obviously become an issue in the last 15 years. Prior to 2010, this wasn't really that big of a problem. Hospitals and clinics were allowed to contract with pharmacies. They were allowed with a small group of them, maybe a handful, 5 or 6, or depending on where you are in a rural area, if it was a closer drive. But in 2010, HRSA removed the limitation and allowed any covered entity, including facilities that have pharmacies on site, to contract. So you saw this explosion go from 1,500 contract pharmacies in 2010 to 35,000 today. And on top of that, each of those pharmacies gets to have contracts with multiple entities. So we're over 210,000 contracts nationwide. This has made a program go from about $3.5 billion 15 years ago to over $66 billion today, with no demonstrable benefit to patients whatsoever because, like I said, none of them know if they're 340B. You don't see big signs at hospitals or even in for-profit pharmacies saying, having trouble affording your discount or affording your drugs? Ask if you're 340B. Those don't exist. And if they do, it may be 1% of the time. So I think utilizing that money a little bit better, ensuring patients understand that they shouldn't be paying list prices for a drug would be much more preferable to the way the system is now. But also, with the state legislation, this is a federal program. The federal government, for better or for worse, at the snail's pace that they move, they need to reform this program. And we, as an industry, have been begging for it for years. The community health centers at the national level have been asking and begging for it for years. Even a lot of the pharmacies, because pharmacies, especially the independent pharmacists, they kind of get the short end of the stick at times on this program as well. So we're seeing a lot of problems. We're seeing more and more for-profit entities enter into the system. Private equity with the purchase of Walgreens. This is one of their biggest business units at Walgreens. Is certainly a question that needs to be looked at. There's billions of dollars just in the system going to everybody but a patient at the end of the day.
Definitely. And then Peter, I'll stay with you. Just kind of, obviously we've talked a lot about PBM reform, 340B. What are other things that lawmakers at the state level, at least, maybe federal if we want to get into that, can or should be looking at as they look to address prescription drug cost?
I mean, there is a big problem, like I said earlier, with the consolidation and vertical integration in all these systems. The Federal Trade Commission has been looking at PBMs. There's been a lot of questions about whether, I understand that however the contract is written, as Johnny explained, that it can be passed on to the plan sponsor, but more and more often the plan sponsor owns the PBM or the PBM owns the plan sponsor. We're seeing that especially with the big three, with CVS and Optum and Express Scripts all being owned or owning insurance companies, specialty pharmacies, mail-order pharmacies. Optum is owned by UnitedHealth Group. They've been purchasing physician practices and outpatient surgical centers. And I get it. All this consolidation was kind of pushed on post-Affordable Care Act to try and deal with the restrictions from the medical loss ratio. It's one of the reasons. So, like I said, like we've all said, there are unintended consequences when you start tinkering in healthcare. There's always going to be that balloon pop up somewhere else. So, talking about that, but I mean, as far as it ensures essentially that the patient gets lost in the shuffle here. It ensures that patients aren't getting savings. When the pharmaceutical industry is providing $350 billion a year in rebates and we're still having patients pay list price, is really hard thing for us to take, because we take all the beating, even though all this money's out here. And like I said, on 340B, that's $66 billion. You talk about Medicaid, that's $51 billion in 2023. Part D is over $200 billion. It's, this is a lot of money that our industry is putting back into the system, but still really not sure if patients are seeing any of it at the end of the day.
So, Lou, I want to go to you. Are there anything you think lawmakers need to be looking at, need to be thinking about when they hope to address the prescription drug cost issue?
I think this is a complicated thing, again, and I'm not for demonizing any aspect of the supply chain. But I mean, there's some things that, we really have to think hard about. One of the things that kind of came up this year was this whole PDAB, Prescription Drug Advisory Board. And honestly, it's well intended, but I mean, it's something that I see, superfluous. Another barrier, a regulatory barrier that kind of prevents people from doing that. And we already have an 8-person P&T committee at the state level of medically licensed and trained professionals that I used to negotiate with to decide what should be on formulary based on cost and based on efficacy. The most important, the two things. Well, efficacy first and then cost. So it's again, unintended consequences of trying to do the right thing, but just not going at it in the right format. Those are the types of things that we should stay away from. And I also think, this is everybody in this room is or will be a patient at some point, okay? 2023 marked a point in time where 1/2 the baby boomer population had retired, quote unquote, until this last couple weeks, But of course, by 2030, the other half will be retiring. So that continued acceleration is impacting a lot of different things. The merger and acquisition of different businesses. If you have a pharmacy, if you have a medical practice, a doctor's or a dentist's office, you're rolling that up if you don't have a succession plan for it. So it's just a natural cost. I mean, I think we need to look at how do we incentivize more people to go into those things. I'm a type of person who looks at how do you increase how do you put more things in the funnel, not how do you make the funnel more restricted. And I think if we put more things in the funnel, more people in allied health sciences and the like, that's going to help us in the long run. Because I hear that everywhere in the healthcare supply chain. There is a shortage of allied health professionals. Everywhere, urban and rural areas. So I mean, we need to affect that. And ultimately, some of us we hope we're not going to be treated by a robot at some point. We don't know, but that. We want to make sure that we impact that and have the right people treating us in those areas and have the care that's required.
Absolutely. Representative Manley, we'll go to you. You mentioned that over the past year you've chaired committees that have been looking at drug costs, PBMs and other things. Just what are some of the other things that maybe haven't been mentioned yet you think lawmakers and your colleagues should be looking at as they look to address this issue?
I do agree with Lou, so I want to put that on the record. The more people we can get, but it's not just healthcare. We have shortages of professionals everywhere, even in the trades.
Right.
Those are professionals, tradesmen. We have that. Believe it or not, everybody in Springfield isn't a genius, and we get our good ideas from people that take the time to bring their expertises to the table. So I'm looking at them and grateful for everything they've taught me. What we have to remember is while they figure out who's going to make more money, right? And the business model is the business model. And while they fight for it, there's people at the bottom of the funnel that just need their insulin. They have no idea how to figure out a vertically integrated system or what pharma does or doesn't do or what PBMs do or don't do. We don't want our pharmacies to close. People just want to live their lives. And whatever we can do to help with that, but things are expensive. We know that. So somehow everybody's got to sit down and figure out how they can help make this better. And it only would take a little bit, just a little, to help get people what they need and make it look as if, like when we walk the walk and talk to doctors, if you care about people and access and health care and making sure people live better lives, then show them that.
Mm-hmm. Fantastic. I see we have just under 8 minutes left, so I do want to open up real quick for any audience questions. If you have any questions, please raise your hand. I'll call on you as I see you. And if you can, just let us know who you're directing your question toward. All right. Oh, I do see one. Yep.
And Mr. Garcia, I'm really happy to hear you talk about transparency. I'm a 20-year independent pharmacy owner. We stopped patients that have insurance that we couldn't afford to anymore. When I opened my business from scratch 20 years ago, I was signing contracts that I wasn't very happy with. At the end, I was signing contracts with $0 dispensing fees. All of our clients are dispensable. Haven't stopped holding up. So, I guess my question is that. So if there's transparency, why are your members putting out contracts that have $0 income? How is the services that we need to provide for our patients, how is that worth doing?
Yeah, so thanks for the question. I mean, so I'm a pharmacist as well. It's been a while since I practiced, but the market's changing. Depending on the type of network that you were set up with, depending if you were with PSA or not, right? There's a lot of factors that go into that, determine how your dispensing fees are. The way that the contracts are written, though, is that you should have offset costs. You may lose some money on a brand name product, but you'll make it up on generics, or you'll make it up on volume. So that's the way that the contracts are written, is to balance that.
Okay.
So there is no loss that you make up on volume. That's just basic business concept. You don't lose money on anything and make up on it in volume.
Yeah, and I would also say, I mean, as things are changing, as we're evolving, I think it's important for the practice of pharmacy to evolve as well. We are pro top of pharmacist license, so being able to prescribe medications that, under protocol or whatever, that's another revenue stream there. Doing MTM is another way that you can increase your revenue by sitting down with the patient, going through the medications, making sure that they have everything they need. So I think the pharmacy market needs to adjust a little bit. Not saying a lot, because there's still importance in the dispensing medications, but I think getting pharmacists more into the clinical role, getting them as provider status, things like that will help shift the market a little bit more so that people like you are not struggling as much.
Okay, great. Any other questions? Oh, yes, sir.
Hi, my name is Jose. I'm the Director of Pharmacy for Meridian of Illinois. We're a managed care MCO. So to kind of tag along to two things. Number one, tag along what Johnny said. As Meridian, we do have a program for independent pharmacies to talk to patients about their medications, and we are incentivizing them to talk to patients and get them to take their medications. Garth knows about this, Chris knows about this too. It's a great program for pharmacists to practice at the top of their license. We have it for our Medicare and our marketplace lines of business. So again, a great opportunity. Representative Manley, I want to actually address the question to you. We talk. I love your approach of everyone getting together and everyone talking about different how we can kind of work together on this. One of the things that I haven't noticed we talk about is high-cost, one-time gene therapies that will have a handful of patients taking, but will cost upwards of $15 to $20 million in aggregate. So they're like at least $2 million per dose. Is there a plan, or what is kind of being discussed at the legislative level to help address some of those, high-cost, one-time use drugs?
I don't even know what that is. I'm one of those non-geniuses that work in Springfield. This is fascinating stuff. Does anybody? I'm looking at Chris.
Oh, I see Johnny. Yep, yeah.
I can help a little bit.
Yep, the Johnny and Lou, yeah.
I think value-based arrangements are really important in the gene therapy.
One hard thing at a time, okay?
So the value-based arrangements, right? Is the therapy going to truly work for that patient? And if so, it becomes a payment plan for the insurer to pay for that.
So like Zolgensma, Evrysdi, Elevitus has been in the news, Skysana are examples. So these are drugs used for things like Duchenne's muscular dystrophy. Some of them are used now for sickle cell disease. They cost upwards of $2 million, but they're only, like in Illinois, I think, there may be like 20 patients total in Illinois Medicaid that are eligible for these drugs. But 20 times 2 is $40 million, which is what Garth said is the number that is what we reimburse the pharmacy. So again, I'd love to discuss this more with you, but it's just something that I feel like, we're talking about diabetes and hypertension and cholesterol, but this is something that can also throw off the state's budget.
Great. Yeah, Lou or Peter, did you?
I was just gonna say, as John was saying, the alternative, all the companies who are developing these drugs are coming up with alternative payment methods for whatever the payer might be, even if it's somebody who's self-pay, working with them. Nobody's going to be paying $2 million out of pocket, not even Medicaid, quite frankly. And we had the same issue back in 2015 with hepatitis C. There was a cure for hepatitis C that came out. Every single Medicaid director in the country was afraid that it was going to bankrupt the system. And then multiple other drugs came on, competitors came on, they
Can you
figured out.
imagine if that's your child? Think about that. Well, we're talking about money. That's really important. But what if it's your son or your daughter? Right? These are important. We always forget about the people, you guys. We're forgetting about there's real people at the end of the supply chain. There's people that are sick, people that, depend on us.
Absolutely.
Sorry.
Oh, no, it's just, so the cost has come down. That's a different example to use, but these are small, like you said, tiny patient populations who would otherwise die without these treatments. So all of our companies are trying to find ways to make them more affordable, even if it's a small patient pool.
Definitely. Lou, do you want to close this out? Did you have anything you want to add?
No, on that, I think, it's really, innovation's going to kind of guide us on that. I think, it's going to, we're at the advent of quantum computing kind of exploding. We're at the advent of a lot of technology helping ameliorate the clinical trials that go into, the upfront expenses that go into it. I was telling our team a story of being on a product launch team. I'm going to date myself. But at the end of it, all the people, and later, Manley, you'll be impressed with this, because all the people that went through the clinical trials, it was amazing. I heard their stories firsthand. It was amazing that they were thankful to have had access to the therapy during the clinical trial. But the most important thing, it speaks to the bureaucracy of our NDA process and our therapy process at the federal level. And I sat we took a team picture next to 2 semis full of bankers' boxes of clinical trial data that was going to get shipped off to Washington. Now, today, that would be several trillion terabytes of data. Okay, but just to show you how much goes in on the front side to get some of these therapies there, that's research. And all of those are representative of jobs and lives that are impacted, whether you're on the placebo or whether you're on the actual control trial. I'm speaking at my essence as a biochemistry major, of how this all went down. But this is the upfront costs that go into this. And I'm not saying that it doesn't impact patients, but it's important that we understand the process we go through that and the complexity, the bureaucracy in Washington to get us there.
All right, Chris, let's close this out.
I'm a little bit worried I'm going to get myself in trouble with this. But I think if we go back to those hepatitis C drugs and the gene therapies, I think we really have to look at the world market. The cost of the hep C drugs in the United States was substantially higher than it was in other countries. And so, right, I don't want to talk into a lot of the politics and that are going on in the world right now, but there's got to be a better balance there too. Does the United States continue to carry some of that burden compared to other countries? And again, I'm not making anybody the enemy or not trying to, right? But I think, why is the U.S. price so much higher than all the other countries in the world, right? That's something we have to look at. And is it negotiating power? Is it other ways we can approach our system? I'm not suggesting we get rid of capitalism, right? I want to say that too. But what I am suggesting is there might be better ways of negotiating better prices for Americans, right? People in the U.S. while also not harming the rest of the world too.
Fantastic. Great. Well, we are just past 10 o'clock, so I want to give a big thanks to our wonderful panelists for taking time out today. This has been a great discussion. So many more questions we could have gotten to today, but I can thank you all for coming out today on a pretty cold, miserable morning. We'll hopefully be back here in June, so keep your eyes peeled to healthnewsillinois.com for more information on that. And with that, I want to wish you all a great rest of your day. Thanks so much for coming out. Appreciate it.